What's up, Ninja Nerds? In this video today, we're going to be talking about amyloidosis. And again, if you guys are watching these clinical medicine series, I hope that you guys are liking them. And if you do like them, please support us. Some simple ways that you can do that for this video is hit the like button, comment down in the comment section, and also subscribe. Also, I really believe in this, that we as a team work really hard to provide high quality notes, illustrations, and great quiz questions to truly test your knowledge. And you guys can become a member on our website. If you go down in the description box below, click on that link to our website, you guys would have access to all of these things. So go check that out. But without further ado, let's get into the pathophys of amyloidosis. All right, my friends, so let's start talking about the pathophys of amyloidosis. Now, this is a disease where basically it's a buildup of amyloid proteins. These are misfolded proteins that when they accumulate in specific tissues, they trigger the apoptosis of those tissues, and that'll lead to tissue damage. There's a lot of tissues that can be affected in amyloidosis. It's oftentimes a multisystem disease. But the big thing to remember is that amyloidosis can actually be broken down into a couple different subtypes. And so I want you guys to remember that as AL, and oftentimes the A in front of it is for the amyloid, and then the misfolded type of protein is what follows afterwards, and that's L. L is for the light chains. So it's important to remember that this is a disease that is oftentimes seen in what's called plasma cell disorders. So sometimes they call them plasma cell disorders, sometimes they call them plasma cell dyscrasias. It's the same thing. We talked about it in our initial video. What did that encompass? That encompassed things like multiple myeloma, monoclonal gammopathy of undetermined significance, and to a small degree, Waldenstrom's macroglobulinemia. So again, AL amyloidosis is primarily going to be multiple myeloma and MGUS. So with these diseases, when you have a plasma cell disorder, there's a malignancy or a pre-malignant condition of those plasma cells. So here are our plasma cells. What's happening with these plasma cells? Well, if you guys go back, these abnormal malignant plasma cells are producing an undesirable amount of antibodies, right? And these are called immunoglobulins, and they could be IgG, they could be IgA, right? More often than not, they're immunoglobulin G, but they're going to be producing these antibodies. And if you guys remember, antibodies have different types of heavy chains, and then they have these like little things off the side like light chains. Well, in certain types of plasma cell disorders, especially multiple myeloma and MGUS, they produce an excess amount of these light chains. So there's a lot of light chains. And so that's what you're really going to see is a lot of these light chains. So let's say here we have plasma cells. They're producing a lot of immunoglobulins, but there's specific components of those immunoglobulins that they're producing a lot more of. And again, what are these? These are your light chains. Let's highlight that. So there's an increased number of light chains. These light chains, per se, do have specific types of names. So sometimes we refer to them as the kappa and lambda light chains. But I don't want you guys to focus too much on that because that's what we discussed in plasma cell disorders. What I want you to know is these plasma cells are just pumping out these light chains. When you produce too many of these proteins, they have a normal morphology. What happens is in certain large quantities, they can misfold. And then they can clog up tissues, right? And that's where we get problems. So these light chains, they undergo a misfolding process and they become more of like sheets, beta-pleated sheets. That's where we get the disease process. So here's our light chains. And then all I'm going to annotate here is, let's take this normal structure and now let's make them really misfolded. And then what they kind of do is they take on this beta-pleated sheet pattern. The problem with beta-pleated sheets is they're really hard to break down by proteasomes, and a lot of proteolysis can't really work well against these, and so they build up. Now, this misfolded light chains is really what we call amyloid light chains. So again, what are these now? These are the misfolded light chains. Okay, so now we've generated a lot of these abnormal misfolded light chains. They can't be broken down. They're unable to be completely broken down, so they build up. Remember I told you, these amyloid proteins, when they build up in tissues, they clog up these tissues like a pooper. These tissues start to undergo damage because it undergoes apoptosis within that tissue. So now here, these guys are going to go and they're going to start depositing into tissues. And when they do that, this is going to lead to our undesirable tissue damage. Now you may be asking, what are these tissues that are oftentimes affected? It really depends upon the subtype. But AL amyloidosis is like the Mac Daddy of all the amyloidoses. It likes to jack up all these tissues. So these patients could get GI involvement. They could get CNS involvement and peripheral nervous system involvement. They can get cardiac involvement, renal involvement, musculoskeletal, cutaneous involvement, but they're going to trigger this tissue damage that we see here. And that's the problem, is because when these things accumulate in these tissues, they trigger apoptosis of the tissue. Now, this is one way of thinking about these. The next one is AA amyloidosis. Now this one's the most common, right? So when you see these, this is the most common. This one right here, I'd say it's the second most common. And this one is oftentimes seen in states of chronic inflammation. What are diseases that you have chronic inflammation? Autoimmune diseases. What are the two big ones that we see a lot? RA, SLE. What about a disease where your immune system is attacking the intestinal tissue, especially in the colon or in the small intestine? Inflammatory bowel disease. So these are really, really big ones to remember. So again, remember RA, SLE, and also don't forget inflammatory bowel disease. Now, it also could be due to chronic infections like tuberculosis, but how common is tuberculosis? It's not super. It could be chronic osteomyelitis. We could see this in. Not something I want you to think about. I want you to think about these. All right, another one that's kind of like, they like to test it on the exam. It's a fickle one. It's a weird one, but you know, the exam, sometimes they like to ask things that are super rare, but it's called familial Mediterranean fever. And so FMF is something that we see in patients who have a family history. They're usually somewhere in that Mediterranean part of the geographical parts of the world, and they present with fever. And here's the other thing, serosal inflammation. What the stink is serosal inflammation? They get pleuritis, pericarditis, peritonitis. Mechanism-wise, we don't know. It may have something to do with neutrophils triggering a lot of inflammation undesirably, but we know it's a familial aspect. We know it's in a specific Mediterranean belt of the geography within the world. And then also we know that they have fevers that are kind of coming on cyclically, and then also they have serosal inflammation. So again, which one would that be associated with? Familial Mediterranean fever. Also sometimes called FMF. Now, in familial Mediterranean fever, one of the big things that I want you guys to remember is, again, don't forget this serosal inflammation. So in the vignette, you'll come in, you'll have a patient who maybe has some of these tissues that are involved, but they'll come in with fevers, and they'll come in with complaints of maybe pericarditis, such as chest pain, pleuritis, such as shortness of breath. And maybe they could also come in with a pleuritic chest pain as well. But on top of that, they may also come in with peritonitis, so abdominal pain. So look for those vague symptoms. Look for a family history. Look for that Mediterranean ancestry, and it may cue you in to think about this type of AA amyloidosis. All right, either way, in all of these scenarios, these guys are triggering inflammation. What's your trigger for a lot of the cytokines? I've probably written them on the board like a million times, but do you guys remember it's always like interleukin 1 is a big one. Its best friend, tumor necrotic factor alpha, also likes to throw its jabs in there. But another really big one is interleukin 6, right? And all of these are released in pretty significant amounts, especially in inflammation. So all of these are causing inflammation systemically. When that happens, these guys like to go and bind onto the liver receptors, especially interleukin 6. They hit the liver, and the liver responds by producing what's called acute phase reactant protein. So that's what it's going to make. So it's going to make these things, again, a lot of them. It's going to increase the production of acute phase reactants. And there's a lot of these. If you guys are out there listening, what are some of them that we always test for? ESR, CRP is probably the most prominent ones clinically that we utilize. But there's another one, and we don't often test for this one. I can't say I've ever seen it in clinical practice, but there's a very specific one that I want you guys to know. So the common ones, I'll bring it over here, common that we test for, and the non-common that we test for. So here's going to be, we'll say commonly tested in practice. And then here is not commonly tested in practice, but relevant to the actual disease process. Again, what are those? We would see a bump in their ESR, a bump in their CRP. And there's even another one like ferritin, which we also can check, but these are oftentimes your inflammatory markers that we test for clinically. The one that we don't test for that's actually pertinent to this disease, it's called serum amyloid A. All right, sometimes we abbreviate this SAA. Now let's actually make this protein pink. So here's this pink protein, and we're gonna just draw it like this. So here's our pink protein, and maybe it has a globular structure to it. And you're producing a lot of this protein in this scenario, of this inflammation that's occurring. Well, when you have lots of these proteins, guess what they can do? Unfortunately, if this is persistent chronic inflammation, they can misfold. And let's make these big globular proteins, let's make them now these big globular beta-pleated sheets. What's the problem with this? Can they be broken down easily? No. Because they can't be broken down easily, what can they do? They can build up in tissues, cause apoptosis of those tissues and lead to tissue damage. So here, what we're gonna have is we're gonna have an increase in the misfolded SAA. I'm gonna write it down. SAA, increase misfolded SAA, which is the serum amyloid A. This is gonna go deposit into the tissues, and again, that's gonna lead to that undesirable tissue damage that we see. And this one, believe it or not, I'll talk about it later, it really doesn't like to affect the heart. It favors the kidneys. This one, it can hit almost every single organ. But this one, it loves to attack the kidneys, and we'll talk about that. All right, so this one, you're looking for a plasma cell disorder. Real quick, what would be another thing? If I'm thinking plasma disorders like MM, what's another thing that I would look for? What is the classic, we use it, crab criteria. So look for a patient who has multiple myeloma. If they have hypercalcemia, renal failure, they have anemia, they have bone pain from those lytic lesions, and they're also having some tissue damage from this kind of amyloid deposits, you're definitely want to think about this as the cause. If a patient's coming in with joint pain, some type of history of like frequent bowel alterations and bloody diarrhea and malabsorption, you may be thinking about inflammatory bowel disease. If you have a child, a younger person coming in with fevers and serosal inflammation, you'll think about this one. So use your history to your advantage. This one's an interesting one. I'd say it's a small proportion, but it's something to think about on the exams. And so there is two types. And so again, it's always amyloid, serum amyloid A. So amyloid, SAA. Amyloid, TTR, transthyretin. And there's two things that I want you to remember for this. There's two types. One is it is mutated, TTR. In other words, this is one type. This one usually likes to target the heart and the nerves. You don't see this in older individuals, all right? This one has a familial aspect to it. So you'll be looking for someone who is a little bit younger, and you'll be looking for a family history, all right? So again, which one do we call this one? There's two names. I would just call them according to what we're going to talk about later. You can do familial, you can do hereditary. I think I just prefer to do the familial. Just don't confuse it with this one though, all right? This is a familial amyloid transthyretin amyloidosis, all right? This one loves the kidneys. This one loves the heart. And also, you'll notice the difference of these later when we get into the diagnosis on how we differentiate the type of protein. Now, the other one is, it's a normal, so it's weird. This one is you have a normal TTR protein. But the problem with this is that over time, that protein builds up. So if you're living 80, 90 years of age and you're building up this protein, it can cause some damage. So we call this senile, right? Because you see this more in the older age range. So senile ATTR, which is the amyloid transthyretin, this is the one that we would see in older individuals, greater than 70 years of age. They probably don't have that familial aspect to it. And it's primarily only the heart. That's what you have to look for in the history. So what happens here is in both of these to a degree, there is this TTR protein. It's just when we look at this, let's say here, I have the TTR protein, and here I have the mutated one. So in this one, you represent the TTR protein. Let's do it here in this maroonish color here. So here I'm gonna represent the TTR like this. Let's say this is a normal TTR. And then over here, I'm gonna represent this other one, and I'm gonna draw this one kind of like funky like this. So here's the mutated TTR. Now, the difference here is if I have, in this scenario, I have the mutated let's say TTR. And then here, I have the normal TTR protein. How do these cause tissue damage? Well, really what happens is, in this scenario, the normal TTR protein, over time, consistent damage, that's what I want you to remember, is it's going to be over time. And I'm talking a person who is really old. So over time, that deposition of the normal TTR protein will cause tissue damage. The difference from this one is that this mutated TTR is now going to actually do what? It can easily misfold. And when it misfolds, it becomes resistant to being broken down. So that's what I want you to represent here, is that now this guy will undergo misfolding, and it'll turn from maybe a globular protein like this to becoming more beta-pleated. So now, in this scenario, what happens? In this scenario, you're getting this weird protein here, and then what I'm going to do here is I'm going to have this puppy go over here, and it's going to precipitate the same thing, that tissue damage. So for this one, I'm getting an increase in the misfolded TTR. So increase in misfolded TTR. That becomes resistant to breakdown and loves to deposit in tissues. The preferable tissues is the cardiac tissue and the neural tissue. So you're seeing how a lot of these can deposit in the tissue, and really we differentiate them based upon the type of protein. You're probably already asking, Zach, how am I supposed to differentiate the type of protein? Is there a specific test? Yeah. It's kind of like the Maury show whenever they're like, who's the father kind of thing. We have mass spectroscopy or mass spectrometry that we can actually utilize to tell us which one of these proteins are actually the problem. And we do that from like a tissue biopsy sample. But we'll get to that. It's just utilizing history that's going to be more critical for this step too. Now, this last one here is probably the one that you can see, but there's only a certain amount of things that we can test often on this one. And it's called amyloid beta-2 microglobulin amyloidosis. Now, this one we really only see in two scenarios, and I'd say the first one is the more common one. And this is what you're going to want to look for. So we kind of see a theme. Plasma cell disorders, look for the Crab criteria. Here, look for features of joint, kind of like inflammatory diseases, GI complaints, fevers that are within the Mediterranean ancestry, and serosal inflammation. Here, you're looking for a family history of nerve and cardiac problems. Here, you're looking for a person who's really old with just cardiac amyloidosis. What are you looking for here? You're looking for a patient who's been on dialysis for a long time. And when I say a long time, how long? Oftentimes in the exam, what you want to see is a patient on it for more than 10 years. That's a decent amount of time. And so therefore, you probably have a patient who also has underlying end-stage renal disease. Why is this pertinent? Well, the kidneys are supposed to clear a protein. So there's a protein that our body normally makes, and it's called beta-2 microglobulin. And it's supposed to clear it. So what if you have bad kidneys? Well, dialysis hopefully would clear this, but dialysis isn't great at clearing it over time. You actually need what's called high cutoff or high flux dialysis, really. So the kidneys aren't doing a good job, and dialysis may not be doing as well of a job as you want at clearing that beta-2 microglobulin. So it's not being lost into the urine, sadly, because it's supposed to be excreted, or it's not being lost from dialysis. And so because of that, if you have damaged kidneys, you're supposed to be putting this thing out. But if you're not putting this out in the urine, what's going to happen? Because it's supposed to run through here and then get filtered. If it's not, it's going to build up. So then as a result, we're going to do what? I'm going to have a lot of this protein. So we've done a lot of different colors. Let's actually just make this one green. So here, let's say, put some of these markers down here. Let's say here I have my beta-2 microglobulin, and we're just going to show it like this. Here's my globular protein right here. And it's supposed to be excreted, but you're not excreting it. What happens? It's going to build up. So then you're going to have an increase in this beta-2 microglobulin protein. You get the point that as proteins potentially build up, they can undergo transformational changes in their structure. So what if this protein that was nice and globular like this decides to misfold? I think you guys get the point. What's going to happen? It's going to become more beta-pleated. And when it becomes more beta-pleated, is it easy to break down? No. If it's not easy to break down, then what happens? It'll start to build up. If it starts to build up around tissues, what's it going to do? It's going to cause a lot of apoptosis of that tissue. And if it causes the apoptosis of that tissue, what's going to happen to the tissue? It's going to become damaged. And it's going to cause a lot of systemic effects. And that's what we're going to see is this type of similar process. So you see how all of these lead to the same thing. We just have to really utilize our clinical gestalt to say, what in the history tells me the type it could be? And then also, what kind of diagnostic test would be helpful in telling me which one of these is the problem? Before we do that, I want us to talk about this tissue damage and what are the most common organs, because you're going to have a patient coming into you and saying, hey doc, I got cardiac problems. No, they're going to come in with some complaints. You have to then diagnose them with that and say, what was the reason for this? I wonder if it's because of amyloidosis. Let's do that now. So when a patient comes in with amyloidosis, it's not like, a patient with like appendicitis where it's kind of easier, where they come in with localized pain within that appendix area. It's like, oh man, my right lower quadrant, bro. That's a little bit more obvious for me to say, they probably have appendicitis. Let me figure out the test that I need to find that inflammation and go from there. It's a little bit more challenging with things like this, amyloidosis, because it's not a strict, they present the same way. Oftentimes they'll present with very, very specific things that are tested on the exam, but they have a lot of multifactorial involvement. It's like thyroid disorders. They have a lot of different systemic involvement. You have to kind of just think about it. In certain types of those systems, when it pops up, it's not normal for that disease. And so you got to think, okay, what would trigger this? And that may lead you down the road of amyloidosis. And if I were to leave you with any of these and you say, okay, I'm done with the video, the two biggest ones are going to be your cardiac and renal involvement. So when a patient comes in with features of restrictive cardiomyopathy, or features of nephrotic syndrome, that should make you think about amyloidosis. The other ones, they are important and they help with the whole clinical picture, but they're not going to be the most common way that you'll see them on the exam. It's going to be cardiomyopathy and it's going to be nephrotic syndrome. So let's discuss that. Cardiac involvement, out of all of those subtypes, it is kind of important to know which one is going to be more likely to hit the heart, right? Because it could help out in your diagnostic schema. And so if we go through these and we write AL, AA, ATTR, and A beta-2 microglobulin. I want you to kind of list out of these which ones are the most likely to involve the heart. And I'll do it with a plus symbol and a minus symbol. This one loves to attack the heart. This one doesn't really involve the heart, so that should be helpful when you think about this. This one loves the heart, and this one doesn't involve the heart. So with that being said, these two are the ones that we see the problems in. So whenever a patient comes in with restrictive cardiomyopathy, we have to know, what does that look like? Well, these guys, they deposit proteins. This is light chains, this is the TTR. So let's say here, I deposit those. Let's see, what color? It was baby blue for the amyloid, so let's kind of deposit some here for the AL. And then the transthyretin was this maroon color. So let's just kind of use that respectively, I suppose, and deposit some of these maroon TTR proteins here. Well, when they deposit, they oftentimes love to deposit into the ventricles, along the septum. What kind of issues would I get with that? Well, it really likes to hit both ventricles, but you're going to see more systemic involvement in the right heart. So the ventricles are going to become very, very stiff, and they're going to become a little bit more thick. So thick ventricles. And the problem with that is that when you have this, it definitely is biventricular, but you see more systemic involvement from that right side. And so this is what you see in a picture of a patient developing what's called restrictive cardiomyopathy. That's usually going to be the most common picture, is they're going to get this thing called restrictive cardiomyopathy. So basically, imagine you have these like super thick ventricles that aren't very, very compliant. They're not as desirable to, whenever blood is filling into them, to expand. Well, that's a problem, because if you can't have good preload, you can't get good cardiac output. And oftentimes the most common way that this will present is congestive heart failure. But it's more often than not right-sided heart failure. So what does right-side heart failure symptoms oftentimes look like? So let's say here I would have a patient with restrictive cardiomyopathy. If I see that, what would be some potential presentations? So I'd say restrictive cardiomyopathy, I would look for the jugular venous distension. That would definitely be one. And do you guys remember when a patient has jugular venous distension, that sign, whenever you take a deep breath in, you should have a good drop where blood, usually would flush down into the heart, right? But in patients who have poor filling, that may stay elevated. And it was a very paradoxical presentation. It was called the Kussmaul sign, right? So look for a Kussmaul sign, which is kind of that distended jugular vein during inspiration, which is kind of a paradoxical presentation. The other thing is you're going to see edema, but the edema is oftentimes more right-sided. And so you can see things like hepatomegaly and ascites, and you can see peripheral edema. And so I'd watch out for that. So watching for any kind of peripheral edema as a potential presentation. You're going to see this more in the legs than you would see it anywhere else, but it's something to think about. Sometimes you can see ascites, it is possible, and that's something to consider as well. But that's one way that I would think about this. There's another thing that can happen though. And when a patient has restrictive cardiomyopathy, we got to get an echo. You see that they would have the thickened ventricles. You'd see that they have biatrial enlargement. You'd have to then probably go a little bit step further and get like a cardiac MRI. And then look to see that they have like late enhancement on the gadolinium on the cardiac MRI. You'd probably have to go and do a technetium-99 scan to look to see if that they would have this amyloid deposits that would kind of light up on that nuclear scan. But there's one other thing that can happen. Imagine that these things deposit along parts of your conduction system. What could happen there? If I deposit these things along the AV node, I could get AV blocks, dude. So that's another thing, is watch for any kind of like conduction blocks. So conduction blocks is a really, really big one, because if I deposit along this conduction system, you can get conduction blocks. What's the most common types of conduction block? That would be an AV node block, right? So I'd be looking for an AV blockade. So this is where whenever we have this patient, we would get an ECG, we may find some AV blocks, we may get an echo and see these stiff, thick ventricles. They have a preserved EF. That's another thing, is if you get an echo for these patients, they'll have a preserved EF. But if you get that cardiac MRI, that technetium-99 tracer, you'll see that patient will have features that should support more of an amyloid picture. So that's something I want you guys to be thinking about for this kind of case. All right? So if a patient comes in, the things that we oftentimes will do to check and kind of look at these things for screening them is you'll oftentimes get an ECG, you'll get an echo, and you'll follow up based upon that, maybe with other testing such as a cardiac MRI and technetium-99 scan. All right, let's come down. The next thing that I also want to be thinking about for this patient is with renal involvement, it's a real big one. And remember I told you when we talked about nephrotic syndrome, that was the topic. There was the primary glomerular disorders like minimal change disease and membranous nephropathy and focal segmental glomerulosclerosis. But there was the secondary ones with like diabetes and then amyloid. Amyloid was a part of that group. So in this patient, you would have to say which one of these is most likely to have that renal involvement. And let's go through it. AL, AA, ATTR, and then A beta-2 microglobulin. It's really only going to be two. It's going to be the light chain and the amyloid, the serum amyloid A1. These ones do not have any kind of renal involvement. So the question is how do these do that? Well, the light chains and the serum amyloid A deposit here. So what color? I had pink and I had blue. So here, you're going to have all of these weird proteins here. I'll just make them as though we had them, which was, they were zigzaggy, right? They were the beta-pleated. And then let's do the pink over here to represent the serum amyloid A that got like that. And what are they gonna do? They're gonna deposit into that basement membrane, baby. They're gonna go over here and clog this thing up. And now, when they deposit into this membrane, it's going to go and it's gonna really mess up the membrane. It's gonna cause some podocytes to get injured. Now, when you injure podocytes, these things are, as you guys remember this? Come on, I know you do from the renal, right? I know learning is stressful sometimes, I do. But sometimes it's good to connect things. Do you guys remember what happens if these kind of deposits get in here and they jack up the podocytes? Let's kind of annotate that here. So what would they do here, just so you know, so you can refer to this later, is they do cause podocyte injury. Now, when you injure your podocytes, what's the problem with that? They're supposed to control protein leakage, bro. Protein's gonna be sifting through this thing. And so now what's gonna happen? I'm gonna start dumping proteins. And unfortunately, the biggest protein that you oftentimes dump into the urine is albumin. And so guess what these patients are gonna start losing into their urine? They're gonna lose a lot of albumin. And so they'll get a lot of what's called, what do we call this? We call this albuminuria, right? We call this albuminuria. Now this is one, but you can also dump other proteins here. So oftentimes we say that it's albuminuria, but really it's protein. We dump albumin, that's probably the most abundant, but you can dump immunoglobulins and other kinds of proteins in there as well. So one thing that we'll do is we like to take a look and check their urine albumin creatinine ratio or their urine protein creatinine ratio. And so if they have lots of albumin, that's going to cause problems. One thing it can do is if you have lots of albumin in the urine, guess what that does? So you guys remember nephrotic syndrome? There's oftentimes a certain criteria that we talked about in renal that you have to meet to truly have this diagnosis. Do you guys remember what it was? There's a couple things. One is you have to have the albumin in the urine that's so high that it lowers the albumin in your blood. So you have what's called hypoalbuminemia. Do you guys remember what albumin does in the blood? It keeps water and things like that in the bloodstream. So if you don't have it, what happens? The water leaks out. What does that do if it gets into the tissue spaces? Causes edema. Because you dump not just albumin, but also other proteins, let's say other proteins. What's another thing that you're going to see a lot of? Proteinuria. And that's the key thing, is that these patients have like wicked high proteins in the urine, bruh. It's going to be crazy high. And how do we usually define that? We say it's got to be at least more than 3 grams in a 24-hour period, right? So they'll have really high proteinuria. And then, again, we gotta really take a look at that. That's the most helpful diagnostic tool, so we can monitor this. Like I can monitor EKGs and echoes and MRIs and things like that. Here, I gotta check the protein in the urine. Another thing that also has to be checked is their lipids, because you dump so much protein that the liver has to compensate and produce lots of, lipid proteins, especially the VLDL and the LDL, and so your lipids go up. And so you end up having what's called hyperlipidemia. These are oftentimes what we need to truly fit the definition of a patient having nephrotic syndrome. And so it's really good to remember that if a patient comes in with heavy proteinuria and edema and low albumin, I wonder if it's amyloidosis. And you got to think about these two. All right. I think we got that down. These are the really big ones. And again, I take away from this that screening for this would be a urine protein creatinine ratio. Screening for this would be echo and ECG and maybe an MRI, depending upon the results. What about the neural involvement? I think it's worthy to talk about this because there is some things that will come up on your exam. And something I would want you guys to think about for these is, when we have all of these, AL, right, AA, ATTR, and A beta-2 microglobulin. It's kind of interesting because AL has a lot of neural involvement, right? So this one's definitely going to get some neural involvement. Serum amyloid A, it's not that much. It's really, really not that much. ATTR, we gotta be really, really careful. And it does have it, but I wanna specify that it truly is, because we gotta be careful, this really only is the familial type, the hereditary type. All right, so it's only the familial. And then A beta-2 microglobulin, this one also has it as well. Now, here's what I want to be super, super careful with. AL loves to present with autonomic neuropathy. All right, so I'm going to write these down later, but this is autonomic neuropathy. Remember that. ATTR is peripheral neuropathy, usually multiple nerve lesions. And A beta-2 is carpal tunnel syndrome, which is a type of peripheral neuropathy if it hits the median nerve. So we'll go through these, but if you have this amyloid deposition, and let's say that it's somewhere within the vicinity of the autonomic nerves, what's going to happen? You have decreased autonomic supply via sympathetic and parasympathetic. So now, if I have a decreased autonomic nervous system, nerve function, this is going to lead me to think that this patient could have a autonomic nervous system neuropathy. This nerve ain't firing, bro. And if this nerve ain't firing, bro, we got some problems. So ANS neuropathy, I think this is worthy to talk about, right? How would these patients oftentimes present? It's usually a couple things. One is orthostasis, bro. You know, you're sitting down, you stand up, and back down you go. Orthostatic hypotension. So look for that in the vitals. That's one thing. The second thing is unfortunately they struggle with they can't get that thing up. All right, that thing's limp. So unfortunately, there's a struggle with impotence or erectile dysfunction. All right. The other thing is the stomach. They can't get that food out of the stomach, unfortunately, and into the small intestine. Things just staying there, sloshing around, causing a lot of nausea and vomiting. That's called gastroparesis. So these are a couple different things that can happen in this scenario. All right. And so again, I really want you to emphasize this thing here that autonomic nervous system neuropathy is pretty common in this one. So let's actually write that out just so that you guys can understand the involvement here. That this one, it really targets more often than not the autonomic nervous system neuropathy. AA, nothing. AA wrong, but ATTR, the familial type, this is polyneuropathy. So this is usually a polyneuropathy. So here, we'll squeeze this mother sucker right here. Polyneuropathy. And oftentimes it's sensory motor, but you know, we know sensory usually goes first, motor comes later. So what happens with this one, TTR, that was maroon, right? Yeah, so we're gonna deposit these somewhere around these nerves, and this is gonna cause sensory motor deficits. If you deposit these, can they function? No, so you can't send signals. You're able to step on a Lego and not know what the heck is going on. You know, and so this is going to cause sensory deficits. So this is going to be your peripheral neuropathy. Your peripheral neuropathy. And this can involve one or it can involve multiple different nerves. But this is the big one to remember here. And usually what's the deficits? It's usually sensory first, motor later. I don't think that's too hard to imagine that if you have the numbness, tingling, paresthesias of the lower extremities, that could tell you about a potential peripheral neuropathy. Again, think about this dude walking on Legos and it's just like nothing's going on, all right? It should hurt like a son of a gun. You ever stepped on a Lego? It's painful. But that's something to think about. This one's the weird one, where these beta-2 microglobulins, for some weird reason, have an affinity for the carpal tunnel. What color did I make? I made that green. These puppies deposit right in here. More of that distal kind of like neuropathy there, right around that median nerve. When it does that, can you send signals down this median nerve division? No. This is going to cause maybe some numbness, some tingling, some paresthesias of that division, usually of the thumb, the pointer finger, the middle finger, and then some parts of the ring finger, right? And then on the back side, on the back of the digits. And then sometimes the muscles here can become a little bit weakened, so you lose some grip strength, and you know, the worst case scenario is the thenar eminence becomes a little bit more atrophied. What's that called? Carpal tunnel syndrome. So this can lead to carpal tunnel syndrome. Here's the weird part. You ever see people walking around with fucking bilateral carpal tunnel syndrome? Probably not often. Amyloidosis is like that weird clinical picture. So it's usually bilateral. And again, what do they oftentimes look like? Well, again, depending upon that division, they could have pain, numbness, tingling within that division of the thumb, the pointer finger, the middle finger, parts of the ring finger, back here. They could have decreased grip strength, and they could have some thenar atrophy. How do we determine if these are not working? Well, if a patient comes in with symptoms of neuropathy, guess what the most, according to the exam, guess what the best diagnostic test is? An EMG and a nerve conduction study. That would help us to say, oh, there's an actual neuropathic process. And then maybe from there we go to an MRI. Same thing like this one. We would start off with an ECG and an echo. We would start off with a urine protein creatinine ratio. And then from there we may go further to cardiac MRIs, radio tracers, renal biopsies, etc. All right, gastrointestinal involvement. I don't want to go too crazy with this one. I only want to pick up really one big thing, and that's within these. It's funny. So AL, AA, ATTR and A beta-2 microglobulin. It's really just these two. Some textbooks say all of them, and that may be true, but it's very minuscule for these two. It's primarily these two. What happens is that in these, they cause the tongue to get gargantuous. Imagine the dude walking around with a big tongue, big old tongue, all right? Things the size of Texas. What is that called? Macroglossia. Now, macroglossia is a common clinical picture here for amyloidosis, especially if it's combined with the restrictive cardiomyopathy and a nephrotic syndrome. Always be thinking about that. Problems with macroglossia is not just that it looks very, very unpleasant, it's also, can you get airflow through that tiny little area when you're sleeping? No. So these patients are super high risk for, oh, do I know this problem? Obstructive sleep apnea. So that may be a way that they could potentially clinically present. The next component here is there is other GI involvement. I'd say they're relatively minuscule and it's not like a super big diagnostic thing. People don't come in with like, hey man, bro, I think my liver is like way too big. nobody comes in and tells you that. They don't say, dude, my spleen's, it's the size of, I can't even imagine. It's the size of Texas in there. They don't do that. And so it's not oftentimes a common kind of complaint. It's just something you may see on the exam, that amyloid protein can deposit into these potential tissues. And so it can deposit into the liver. Sometimes you can get a little bit of cholestasis with that. It can deposit in the spleen. It gets a little bit big, but it's nothing crazy. Oftentimes the real big thing here is you're looking for that hepatosplenomegaly. And I know that this kind of is a tough thing because, we've seen here in heme how many diseases can cause hepatosplenomegaly, right? I think the big thing that I want you guys to take away is this one. So I want to actually make this one red because it's the most important one, is this one, the macroglossia. This is that exam thing where you see this, you should think amyloidosis. The other one here, and they do say that textbook-wise that it is kind of important to remember, is that these amyloid proteins, funny enough, they can deposit onto these intestinal villi. Now, what are the villi for? If you have all of these proteins depositing onto the intestinal villi, they're supposed to increase the absorptive surface area, right? So they're really supposed to help with absorption. Well, if you have this villi, oops, I don't want the blue, I want to stick to the color here of black, that if you have this villi deposition, then what's that going to do to your absorption process? It's going to decrease the absorption. And so when you do that, you take away the structures that are supposed to increase the absorptive surface area. And then if you can't have that, what happens to your absorption? That becomes impaired. And what do we call that when you're limiting your absorption? Malabsorption. And so you could see people with weight loss and diarrhea, nutritional deficiencies of sorts. But this is something to definitely consider. I wouldn't say it's a super, super common one that you're gonna see on your exams, but it is something to potentially consider. But I'd say GI one, definitely don't forget this. Cutaneous involvement is something to consider in patients with amyloidosis, and it could just be easy bruising. Could be a lot of different reasons for that, such as like bone marrow invasion. Because sometimes these proteins can invade the bone marrow. I'd say it's less common, but anemia is pretty common in this disease because you can see it, whether it be due to bone marrow invasion or whether it just be due to a lot of just tissue damage causing inflammation. But cutaneous involvement, it really kind of comes down to the classic picture, which is the raccoon eyes, the periorbital ecchymosis, and that's what you want to look for. But when we talk about this and how it's presenting in patients with amyloidosis, so you have, for example, AL, you have AA, you have ATTR, and you also have A beta-2 microglobulin. Really, the one that I want you guys to remember is going to be this one. These ones don't really have any significant cutaneous involvement. This is the primary one that I want you to consider. And again, the concept here is that you're going to get this kind of bruising, but it's going to kind of stay to the periorbital area that it's going to be the classic kind of look. And so it's called periorbital ecchymosis, but we give it another name. We call this raccoon, the raccoon eyes. And raccoon eyes are also again known as periorbital ecchymosis. And it's cool because it looks a little bit like this. So when we see this type of clinical picture with the combination of restrictive cardiomyopathy, nephrotic syndrome, we also see that they have macroglossia. We maybe even pick up some neural signs, and then you see raccoon eyes, definitely think about amyloidosis. All right, we come to the last one here, and this is the musculoskeletal system involvement. And again, we kind of list our types, AL, AA, ATTR, and A beta-2 microglobulin. Really, any of them can involve the musculoskeletal system. I'd say the most prominent are going to be this one, and this one. You don't see as much of it from this. And so what's going to happen here is that they love to go, any of these, I'm going to represent it here. Maybe I'll put some blue, maybe I'll put some pink, or maroon, and I'll just represent all of these different types of proteins really heavily depositing into these joints. And what happens, it'll produce tissue damage, it'll produce inflammation. And so you're gonna get this picture of arthritis, right? So there are arthralgias, but arthritis would be a really big one. Now, oftentimes it loves to really go after the shoulder joint for some reason. And so I would kind of think about this in a patient with some type of like shoulder arthritis is a big one. And even adding to that, sometimes they can get so much deposition and inflammation and periscapular humeral arthritis that they literally look like they're wearing football pads. I'm not even kidding. I'm not making this up. A classic sign of this is called the shoulder pad sign. It looks a little bit like this. So if a patient comes in with a shoulder pad sign, chronic history of arthritis, definitely be considering the possibility of amyloidosis. So there's a lot of key takeaways from this so far, but I think we'll establish that when we get into our diagnostic approach. Let's do so now. All right, let's move into the diagnostic approach of amyloidosis. So when we think about this, what is the most common way that these patients with amyloidosis will present? To make you even have a suspicion of this, because this is not an easy disease, oftentimes in the clinical vignettes and sometimes in clinical reality, we see nephrotic syndrome as the most common presentation. So nephrotic syndrome is usually that patient who comes in with heavy amounts of proteinuria, right? So a very, very large amount, greater than usually, we'd say 3 grams within a 24-hour period is very, very concerning. Another thing that we would also see is potentially hypoalbuminemia, very, very low albumin in the bloodstream. They would have also hyperlipidemia, and they would have some evidence of edema within the body. Those are things that would make you curious. And what would happen is you would work them up for nephrotic syndrome, you would develop a differential diagnosis. That's when you start thinking about minimal change disease. You start thinking about focal segmental glomerulosclerosis, membranous nephropathy, diabetic nephropathy, and amyloid nephropathy. Unfortunately, a lot of these patients, you would have to probably go the route of considering some type of biopsy to really elucidate which type it is. And that's how you may end up with the diagnosis of amyloidosis. Another common presentation is restrictive cardiomyopathy. So you may have a patient coming in with symptoms of right heart failure. So they may have jugular venous distension. They may have potentially some lower extremity edema. They may have that paradoxical rise of the jugular venous pressure during inspiration called Kussmaul sign. They may have other evidence that when they get an echocardiogram, they show a bilateral kind of stiffening and restricted movement of the ventricles with a little bit of thickening there and biatrial enlargement that also could be concerning. They may even get further testing that yields that they have a restrictive cardiomyopathy. And then upon that, you would diagnose this because what would happen is you'll probably get further imaging like a cardiac MRI. You may even go the routes of getting like a biopsy and find that they have, amyloid deposits. Other less conspicuous ways, and I'd say less common, is things like macroglossia, enlargement of the tongue, neuropathy, especially if it's autonomic or peripheral, or a really, really high yield one that we see is bilateral carpal tunnel syndrome. And raccoon eyes. This can usually suspect potentially a basilar skull fracture or a systemic disease like amyloidosis. But I'd say oftentimes more than not, nephrotic syndrome and restrictive cardiomyopathy, you should definitely have amyloidosis as a part of your differential in that diagnosis. So once we say, okay, this patient came in with nephrotic syndrome, they came in with restrictive cardiomyopathy, what makes me think that it could be amyloidosis? Well, the reason why I would start thinking that is maybe they would have other kind of multi-system involvement. One of the easiest way is to do a tissue biopsy. Now, we can do this a couple different ways. One is we can can do an abdominal fat pad biopsy because that's going to be the less kind of like super invasive option. It's also really decent. It's a pretty good test and you can get pretty good diagnosis just off of that. A lot of the times though, we prefer organ specific. So in other words, if they have nephrotic syndrome, I prefer a renal biopsy. If they have some type of restrictive cardiomyopathy, I may prefer a biopsy of the myocardium. So these are all things that we potentially could do, but an abdominal fat pad biopsy is usually going to be the best and least invasive way of being able to get a diagnosis. So once we do that, we take the tissue. What we do is we use a Congo red stain. And if that Congo red stain upon that shows an apple green birefringence, that is highly, highly, highly suggestive of amyloidosis. You can see here, you see all that kind of apple green kind of birefringence there. That is highly, highly suggestive of amyloidosis. From there, we've really diagnosed that the patient has amyloidosis that's either caused, in this case, this is a patient who has nephrotic syndrome because this is a glomerulus. So you're seeing a lot of the amyloid deposits occurring in the glomerulus. But once we've diagnosed that, we know, okay, they have amyloidosis that's caused their nephrotic syndrome. Well, which type of amyloidosis? Is it AL, AA, ATTR? Is it A beta 2? Well, really, I know that oftentimes more than not, it's AL amyloidosis in this case, but I got to go a little bit further and really elucidate that type. So we do that oftentimes. You can do mass spectrometry or you can do immunohistochemistry to really look at these a little bit better. And we can kind of get specific weights and ideas of what types of proteins are usually built up. So if I see a lot of kappa lambda chains that are coming up on mass spec, that may help me to think about AL amyloidosis. So what we do with AL is we think that this is usually plasma cell disorders. Multiple myeloma is a really big one. So we'll do a SPEP, a UPEP, and we'll immunofixate for free light chains, right? To see if those are super elevated. What do we know about patients who have multiple myeloma? Well, we know that their SPEP would show that they would have an M spike, a UPEP would show that they have a Bench-Jones proteins, and then their free light chain ratio would show that they would have lots and lots and lots of light chains that have grown. And so these are things that would really, really help to tell us that this patient probably has multiple myeloma that's caused their AL amyloidosis. Another way that we can confirm that it's multiple myeloma is usually they have lots of these plasmacytomas that are occurring in the bone marrow. So if I see things like that, that really, really is suggestive of multiple myeloma. In this case, AL amyloidosis. If I said that there was lots of serum amyloid A that came up on mass spec, that would suggest the AA amyloidosis. And then you have to start thinking, could it be due to familial Mediterranean fever, RA, SLE, inflammatory bowel disease? The best way to do that is to think about what? Get the ESR, CRP levels, because usually if those are super elevated, it suggests more of a systemic inflammation and a chronic inflammatory disease of such. And that's where you start thinking about AA amyloidosis, right? Now, the transthyretin is going to be, again, thinking that this could be the normal one that's built up in an old person, so senile, or it's familial. There was a mutation that causes misfolding of the transthyretin protein. So how do we really determine that? Well, we have to do genetic testing for that TTR mutation. If they have the TTR mutation, it's familial, especially if they're associated with cardiomyopathy and polyneuropathy. But if it comes up where they don't have the TTR mutation, but they do have some cardiomyopathy, again, usually no like significant amounts of polyneuropathy, that suggests the senile ATTR amyloidosis. And then lastly, you can bet that if there's lots of beta-2 microglobulin, that would be a possible A beta 2. So how do we really determine that? There's a couple different ways, but oftentimes we just check a beta-2 microglobulin level. And what would we think? Well, it's probably going to be built up. And that would usually suggest, especially in a patient with long-term hemodialysis, greater than 10 years, or end-stage renal disease, that would likely suggest the A beta 2 amyloidosis. All right, that puts everything together to think about this. And again, thinking about it in this way, that most often it's these two presentations that make you think about amyloid. The only way that you make a diagnosis is you need the tissue. Get the tissue biopsy. Abdominal fat pad, very optional. I mean, a very good option, less invasive, but preferred if you had to go with the best gold standard to be organ specific. You see this, it's amyloid. We can further divvy this out to think about which one it is based upon mass spec or immunohistochemistry. And then figuring out based upon that, we can go a little bit further to elucidate specifically these specific subtypes of amyloidosis. All right. Now, the next component here is whenever a patient has amyloidosis, whether it's AL, AA, ATTR, or A beta 2, we always want to consider the possibility of associated complications. We know that the most common is nephrotic syndrome, but don't count out other things like restrictive cardiomyopathy. So whenever we think about this, it's easy to always consider that if a patient has amyloidosis or you suspect them to have amyloidosis, always consider the urine albumin creatinine ratio. That's going to tell you if they have heavy amounts of proteinuria. So if a patient has a very, very high urine albumin and creatinine ratio, where we can really say that they're putting out more than 3 grams of protein within a 24-hour period, we may have that suspicion, okay, this patient may have nephrotic syndrome. And you may be able to catch that and then say from there, do I go to the lengths of saying this could be amyloidosis, right? And even as you're treating these patients, if they have nephrotic syndrome, you should be continuously monitoring that. Now, we also know that this can cause cardiomyopathies, but it also, if these amyloid deposits get inside of the bundle system near the AV bundle, the AV node, you can cause AV blocks. So you definitely want to be watching out on the EKG for any AV blocks. This could be a first degree, this could be a second degree, or it could be even a third degree AV block. Next one is echoes. So again, echoes, I told you, are really good for being able to pick up if there's any restrictive cardiomyopathy here. You can see that this patient has a very, very thick and very less elastic, I'd say, and less kind of distensible myocardium. And that's definitely concerning. But again, we would be able to pick it up here. Another way that we can do these is we can do cardiac MRIs, and we look for like gadolinium enhancement. And if it's late, that means that some of that gadolinium is getting trapped inside of all this amyloid and fibrous deposits. And so it's harder for that gadolinium to actually exit out of the actual myocardium. And so it remains to be enhanced even later in that phase when it shouldn't be. In normal patients, you should not have late gadolinium enhancement. If you do, you're thinking about something that's kind of restricting the gadolinium from getting out of there. And that would be something to think about, especially in amyloidosis. Another thing that we can do is we can do a TC99 scan, and it looks potentially for radiotracer uptake. And all we try to do is we actually try to compare the ribs, the uptake of the rib to the uptake of the myocardium. And if the uptake of the actual myocardium is bigger or greater than the uptake of the ribs, that's highly, highly suggestive of a patient having an increased uptake of that radiotracer, which we can see in patients who have amyloidosis. All right. And then lastly, EMGs, nerve conduction studies are great because neuropathy is a very common presentation. If you pick up neuropathy, again, it could be something to think about as a patient having amyloidosis, but it's not going to be at the top of your differential. Oftentimes, the best ways of being able to pick these things up is a urine albumin creatinine ratio and an echo. All right, let's talk about the treatment of amyloidosis. So when we think about this, there's different types. So we're going to start off with AL amyloidosis. That's one that's actually high yield. But again, we talked about this in multiple myeloma or the plasma cell disorders. So when we think about AL amyloidosis, it's usually secondary to plasma cell disorders, with multiple myeloma being the most common. MGUS, or monoclonal gammopathy of undetermined significance, we don't usually treat. We just monitor. And then if they just happen to develop multiple myeloma, we treat accordingly. So how do we treat this? Well, oftentimes you start off with the VRD therapy. So this is usually like the bortezomib, the lenalidomide, and usually some type of steroid, maybe like a dexamethasone of some sort. The other thing is that if we're trying to condition them for a bone marrow transplant to kind of like help them to have proper plasma cells so they're not producing these abnormal amounts of kappa and lambda light chains, we'll do a high dose melphalan. This will condition them, usually get the bone marrow ready to properly accept a bone marrow transplant. So that's kind of the way that we do that. Is, again, you start off with the VRD therapy, and then from there we'll condition them if they are eligible for a hematopoietic stem cell transplant by giving them high dose melphalan and then follow it up with that stem cell transplant. Now, AA amyloidosis could be to RA, it could be due to inflammatory bowel disease, could be due to SLE, could be due to familial Mediterranean fever. Depending upon if it is all those things or familial Mediterranean fever determines the way that we'll treat. So obviously you have to treat the underlying cause. And for RA, SLE, inflammatory bowel disease, all of those things come down to usually DMARDs or some type of biological agent. Whereas familial Mediterranean fever, you need to know this, my friends. It will likely come up on the exam in some way, shape, or form. It is colchicine. So again, how do we remember this? If it's usually those patients who have RA, SLE, inflammatory bowel disease, you're treating them with DMARDs or some type of biologic. If it is familial Mediterranean fever, it is colchicine. Don't forget that. All right, ATTR amyloidosis depends upon if it's the mutated, the familial, or the non-mutated, the senile ATTR amyloidosis. Well, depending upon that determines if we use a drug that binds to the transthyretin and prevents it from accumulating over time, prevents it from actually leading to this tissue deposition. And that would be tafamidis. So that's going to be the one for the senile or the non-familial ATTR amyloidosis, which we see a lot with the cardiac involvement. The other option is we replace the organ that's abnormally producing the abnormal ATTR protein. And in that mutated form, that's the issue. If we get rid of the organ or we switch the organ to a proper organ able to produce that protein, we might be okay. And so that's where a liver transplant is best for those who produce that mutated form, since it's the source of ATTR, or that, in this case, the mutated transthyretin protein. So again, we kind of go off of this. If it's non-mutated, it's tafamidis. If if it is mutated, we do the liver transplant. This kind of gives us an overall look at how we treat amyloidosis based on if it's AL, the plasma cell disorders, chemo, very high conditioning chemo, and then stem cell transplant. AA, underlying disease needs to be treated. If it's the RA, SLE, inflammatory bowel disease, it is usually DMARDs, biologics, steroids. If it's familial Mediterranean fever, colchicine. ATTR, which have the cardiac amyloidosis, is the most common presentation, usually the polyneuropathies in the familial type. It's taphomitis if it's the not mutated or the senile form, and it's a liver transplant for those who have the familial form. All right, my friends, that really is a big topic on amyloidosis, and I really hope that it made sense. I hope that you guys enjoyed it, learned a lot, and I hope that if a question comes up on it, you'll be able to crush it the Ninja Nerd way. We love you. We thank you so much for being so awesome. And as always, until next time.